Welcome back to another episode of the High Five, where we talk to policy experts and policymakers across the US, asking them 5 questions about the key health information issues facing us here in the US health system and abroad. I'm really excited to be joined today by Mark Sendak. He's on the leadership team for the Health AI Partnership, the co-founder and CEO of Vega Health, and a wonderful friend of AHIMA. Mark, thanks so much for joining us to talk a little AI.
Thank you for having me. It's a pleasure to be here.
So it feels like I was just talking to our team today actually about this, about when AI sort of came onto the mainstream. For me, it feels like my introduction to it started in 2023. It felt like that year, HIMSS and the Vive conferences really exploded with AI. But for you, how did your AI journey start, and what got you curious about the technology and its potential uses in healthcare?
So I had a very unusual background coming into medicine where I actually studied pure math and was very familiar with like high dimensional algebra, geometry. Came to medical school in 2011 is when I started. And really, I was in the right place at the right time with the set of skills and curiosities I had. So Affordable Care Act had just passed. Duke was transitioning to its EHR Epic in 2013. Duke was also establishing the Institute for Health Innovation, which is the place that I would ultimately work. So I was a student helping these faculty aggregate data across data systems to run value-based care programs. Obviously, value-based care requires you to target patients in a more proactive way, which really relied on getting access to data. So I was doing that programming. Um, it started with counting. Andrew, this is what I joke with people. I was working on Duke's high utilizer program in 2012, 2013. This was all the rage in the wake of Atul Gawande's New Yorker
Mhm,
article about high cost patients.
mhm.
At that time, there wasn't a centralized way for Duke to count historical visits within a primary care patient panel. So I
Wow.
literally built a tool to aggregate visits across the different data systems and count. Once we were able to do that, then we just kept looking at more advanced methods. I started taking graduate level courses at Duke in machine learning and statistics. And I pretty quickly realized that with the amount of data and the complexity of clinical decision making, that the field of machine learning was going to have a really huge role in medicine. So since 2014, 15, I've been directly working on building and implementing AI and machine learning tools in healthcare.
It, Starting with counting, I don't know if you've ever seen it's an old film called The Desk Set, and it makes me think back to the original advent for computers generally, right? Because it was a counting office or a math office, and then the
Yeah.
computers came and replaced that. So it's interesting that that's your introduction to AI as almost the extension of that process.
Yeah, it started with very simple things that doctors were trying to do, just like who needs to be enrolled in this special program? Can you help us find those patients? I'll never forget a psychiatrist came to me asking, can you find disruptive patterns of healthcare use?
Hmm.
And I was like, what does that mean? But yeah, it required overlaying different types of encounters with the chief complaints and diagnoses that were presenting in different visits,
Mhm.
combination of inpatient, outpatient, ED. But once again, all of this just started to increase the number of dimensions we were looking at, which also makes problems a better fit for AI and machine learning.
You mentioned that the when you started at Duke, and a lot of this work is done while you were at Duke and in that innovation space. The Duke Health AI partnership, we talked about it. You're on the leadership team for that. It's a great initiative that we're actively engaged in here at AHIMA. How has that been an extension of the work that you've been doing on AI, and what's the overall goal that the partnership's looking to accomplish?
Yeah, once again, we were very fortunate. We were doing the work heads down within Duke. So I often tell people that the first 5 to 7 years I was working at the Duke Institute for Health Innovation, 2015, it started a little bit during COVID, but then really expanded during 2022 when we launched Health AI Partnership. You wouldn't have encountered anything that me or my team had built if you weren't a Duke patient or a Duke clinician. We were invited to be on an advisory council with the Gordon and Betty Moore Foundation in 2021 to inform their grant giving. They got to see under the hood what we were doing at Duke. It was really impressive to them, and they recognized that this was a relatively unique setting where we had a hard money funded team of data scientists, machine learning researchers working alongside with clinicians building these tools. So they gave us a charge of what would it look like to scale these capabilities. So we put our heads together with some other experts in the field, and then we put together the proposal of what became Health AI Partnership. So the way I describe the progression is DHI is really focused on solving Duke's internal problems, working directly with frontline workers to design and implement solutions internally. Health AI Partnership is an extension of that. Now let's think about how do we scale these capabilities across the country. And the mission of Health AI Partnership is to empower healthcare professionals, interdisciplinary teams of healthcare professionals. That's why working with AHIMA is so important for us because there's no one person in a healthcare organization who makes the decisions for how AI is used. It's pervading all different functions, all different business units. And so you need capabilities across a range of professional roles to understand how to make the best use of these tools. And that's how we've grown the national collaborative. One thing I'll add is in the last year, we launched the first cohort of the practice network to do technical assistance in community and rural settings. So I like to tell people that a lot of folks right now, they're trying to define pre-market controls. You see these news articles about there's 6 different standards groups competing to like who's going to set the gold standard. We don't play in that space. So we're not interested in pre-market controls. We're interested in post-market supports. Let's assume that there already is a flurry of AI products on the market that healthcare organizations struggle to make the best use of. And let's support those organizations to scale AI that works and stop using AI that doesn't.
You mentioned, just as an aside, why the focus that you're looking on now is that rural and underserved. What was that market in terms of where you're starting to work now? Was there a functional decision on where to start there versus elsewhere? Is there something that space offers you that the partnership can either fill that gap, or is there more? What caused you to look in that space?
Yeah. So it was part of the original mission. And I'll never forget, we had a phenomenal program officer from the Gordon Betty Moore Foundation, Tommy Wang, who from the beginning gave us the feedback that, look, like we know the Leadership Council is going to consist of folks from Duke, Mayo, Berkeley, DLA Piper, a community member, but the work that you all do can't be for the Dukes and Mayos of the world. And there's another phrase from a very longtime mentor of mine who's been pushing me for the last decade of my career. How do we get AI out of the ivory tower? So I think for me, it's been consistent with that theme of even though today, if you look at the digital divide, the vast majority of expertise for AI is in these well-resourced elite institutions, we have to get those capabilities out of the ivory tower. So where we started with Health AI Partnership was the radical idea of let's just create the best content that we can from the best experts and make it freely available online. And this really was counter positioning all the executive education programs out of elite institutions that you pay $5,000 to $10,000 for to learn about AI. Let's make it freely accessible. Anyone can use it. But Andrew, what we found, and this won't be surprising to anyone, is there's a difference between making content available and then getting that content put into practice, that last mile implementation. So as we were approaching the end of our first phase of funding, we continued the dialogue with the Moore Foundation saying, we think we have to do more to really get out into these community and rural settings to get these best practices implemented. And so that helped us put together the competition that we called the Practice Network. Let's put out an RFP at a national level, have FQHCs and community hospital systems apply to participate, and then we would work directly with them over a 12-month period to do implementations of AI in their contexts.
And so much of that about AI access, if you think about it, the extension, right? It's not only the elite institutions that then have this sort of siloed AI use in there instead of the some of the other institutions that maybe are less resourced. That also impacts the patients and their access to AI tools and being able to have their healthcare impacted by that.
A
And you
hundred.
recently co-published an article on this about eliminating the digital divide by building that local capacity. Did that come out of this work? Did that article, that piece come out of that? And how can health systems help work to get that better equitable access?
Yeah, no, and I appreciate you mentioning that, and I hope we can include a link in the
Of
note.
course, it'll be in the show notes. Yeah.
Yeah, one of if you read that article, we wrote it as a review because we specifically wanted to review the literature of similar technology shifts in healthcare. I think something that we've been facing over the last few years doing this work is AI can feel very disorienting to
Hmm.
folks.
Hmm.
And I will say, and maybe this will be a little bit provocative, I think that there's commercial interests at play to make it disorienting, to
Hmm.
kind of put people in a defensive posture where folks are coming out of the gate saying, this is unlike anything you've ever seen before. This changes everything. You need to be highly skeptical. It's the Wild West. No one knows how to do this right. And on one hand, they create this type of fear, but then they also try to position themselves as sources of authority that then you will delegate authority to for this entity to then be able to decide how AI is used in healthcare. And so I mentioned this at the top of the interview. I mean, the team I've been a part of at Duke, we've been doing this work for 10 years.
Hmm.
In many ways, ChatGPT was a user interface innovation for neural network architectures that were there for several years.
Sure.
And the technology has gotten better year over
Hmm.
year, but we wanted to ground the challenge that we're facing now in the historical context of electronic health records, telemedicine. One of my favorite analogies, and I'll never forget this, like I started medical school in 2011. There was a massive kind of enthusiasm around high utilizer programs. I think over time we saw how difficult it was for those to have impact.
Hmm.
But another program that there was a great deal of enthusiasm was extension of community health outcomes, Project Echo out of University of New
Hmm.
Mexico. And for listeners who aren't aware, this is, I like to call it a stupid simple innovation because it sounds so obvious. But the idea was you had a highly specialized team at the Academic Medical Center in University of New Mexico that patients from across the state drove to 3 to 5 hours to get specialized care for hepatitis C treatment. And what they did and ultimately published in the New England Journal was that if your control arm is patients who drive 3 to 5 hours to an academic medical center, and your intervention arm is patients who receive care in community settings and in
Hmm.
prisons,
Hmm.
with the intervention being virtual calls between the primary care docs in prisons and community settings and the specialist at the academic
Hmm.
medical center, you would have equivalent outcomes.
Okay.
So you didn't have to refer patients to the specialty center.
Hmm.
All you needed to do was break down the silo of expertise and open up channels of communication to diffuse the expertise into community and rural settings. So not that radical. Like, here's a phone call,
Yeah.
here's a virtual, like, video conference. We're going to schedule it. We're going to coordinate for you once or twice a month. Join these sessions and ask the questions of your complex cases. And we can show equivalent outcomes to
Sure.
your patients not being able to access care in their underserved communities. So we did the same thing for AI. So it was like, let's just break down barriers and information silos and make sure that folks doing the last mile work in community and rural settings have direct access to expertise from mentors, from hubs
Hmm.
across the country. And it also started to inspire, well, that's a model that has scaled. Hub and spoke networks have scaled across many different contexts. And so we wrote that piece, and I would say that the proudest part here is that it has 50 co-authors. So huge coordination effort. You work in DC, balancing the interests of many
Sure.
stakeholders. We had to do that with this review. We had folks from industry, folks from consulting, professional lawyers, lots of people from health systems, high resource, low resource, everything in between. But we were able to put together a piece that all 50 stakeholders were excited to get out there.
That kind of consensus building is difficult. I mean, I think we're seeing that in Washington alone. It's
Yes.
listening to you talk about it. It's interesting because it is it's almost like using the things that we learned in the pandemic, but then forgot, and then redoing. Because I think about a conversation I'd had with the tribal communities about utilizing telehealth to get to those patients that would otherwise take hours for the providers
Mhm.
to get to. And it almost just feels like a relearning of things that we already learned and then have kind of walked away from in order to bring AI to the masses.
Yeah, no, and I mean, definitely, this is like my own geekiness. I love reading nonfiction. I love history. And yeah, I mean, there's so much that we can draw from. We've been through this before. AI is
Yeah.
not new. AI does not present unprecedented challenges. And we just have to keep saying that.
One one place that I think that has talked about those challenges, I think a lot, has been in the regulatory space. We've straddled two administrations now, essentially, with this new AI boom. You mentioned
Mhm.
DC earlier, and one administration has kind of taken the tactic of this is an incredible shift, incredibly changing, kind of what you've talked about before, and we need to heavily regulate it and put the guardrails and need to make sure that we're on the ground. The current administration is a little more laissez-faire, I'd say, trying to, let industry dictate a little bit more about how AI is developed and implemented. From a regulatory standpoint, what do you think AI needs to be safe and successful for use in healthcare?
So this is where I'll push back a little bit. And my experience the last 3 years, I think, has in some ways made me more critical of regulatory efforts.
Interesting.
And when I say critical, I don't mean negative. I
Hmm.
mean more nuanced in how I look at the way
Mm.
work is being done. I would say that under the prior administration, there were some very prominent industry-backed efforts for regulatory
Hmm.
capture. And so what you have now, the framing of the question as now it's laissez-faire with
Hmm.
industry deciding, I think at the end of the day, industry interests end
Hmm.
up trying to secure the policies that best interest them.
Okay.
So, in one political environment that is eager to
Hmm.
pass regulation, the regulation ends up being informed and shaped by industry interests.
Okay.
And I would say me and my boss and collaborators, we were some of the first folks to be publicly critical about the equity concerns of assurance labs at Duke, Stanford, and Mayo, and calling out that centralizing federal resources at elite
Mm.
institutions does not address the digital divide
Sure.
challenge. And we stand by that, that community and rural settings need capabilities. And the only way to eliminate the digital divide is to build those capabilities. And the environment today is much less interested in passing regulation to centralize control over market access, which is also an opportunity for industry to make the most of the current environment. So I think I've learned that at the end of the day, it's we always have to be thinking about what's best for the patient.
Hmm.
and what's best for being a physician and working in a healthcare delivery organization. My disposition is always oriented towards how do we empower the delivery organizations to provide the best care to patients. And that's going to be the priority regardless of the political environment. So interestingly for us in Health AI Partnership, I would say that we've had very broad stakeholder engagement and enthusiasm across both administrations
Hmm.
because the work that we're doing speaks to just the common sense need that every organization that handles patient care needs to understand how to make the best use of AI. And that's
Sure.
what we're trying to do.
So from your standpoint of working with those administrations, what is the regulatory space then? I guess a slight change then from what we were talking about before. What's the most helpful to get to that goal? Is it, not net centralized standards, but standards that are frameworks that people can work within? Is it providing spaces for people to speak? What's the best way
Yeah.
for the government to get involved to help that goal?
So this is where I am doing something kind of radical. And this comes from somebody who the first president I ever voted for was Barack Obama. I started medical school in 2011. I was very bullish on the Affordable Care Act.
Hmm.
Lived through the pandemic, working on the pandemic, working on COVID response
Hmm.
for Duke, that is, and saw a lot of the challenges of public sector response to healthcare needs.
Sure.
And as I mentioned earlier, my experience with AI the last few years really got me thinking about, are there ways outside of regulation
Hmm.
that can promote safe, effective, ethical use of AI in healthcare? And where I landed was a commercial business model,
Okay.
which may sound pretty out there. But the analogy that I like to use is we're trying to build the Costco of healthcare AI.
Hmm.
So Costco is one of the most popular companies in the country. Durable differentiation, tons of value for stakeholders, their investors, as well as their members. You pay an annual membership fee to get access to a highly curated marketplace. Costco takes on a ton of effort doing diligence on the front end for what products they put in their stores. You can't go to Costco and pay for shelf space in their stores. You have to be invited into their stores. You have to test in their stores, scale in their stores. And then they still de-risk purchasing on the back end by having a very generous return policy. So even though the FDA regulates food sales, if you go talk to people who sell through Costco, they'll tell you that getting into Costco was much more difficult than getting FDA approval to sell their food in the United States. So here you have a commercial business model that has made quality control a
Hmm.
differentiator through the business model in a way to maximize value for customers. So the idea here is, how do we do that for AI in healthcare? And so what Vega Health is doing is we're
Hmm.
we're adopting a lot of those principles. We're saying, okay, annual fee to get the platform and infrastructure to curate all of your data to be able to evaluate and monitor algorithms. If you're interested in buying a solution, let us do retrospective validation of third-party solutions on your data free of charge, tell you if there's a solution that works best for your patients. If there's no solution that works for your patients, don't buy anything. If there's something that works well for your patients, buy the thing that works best for your patients. As part of the purchase for that solution, we'll do the post-implementation monitoring. And if we see that it's not providing value to you, we'll tell you to stop paying for it.
Hmm. The Costco analogy is so interesting because I'm even thinking like you could go almost a step further with it. Because not only does it's difficult to get in Costco's brands, but then you're also sometimes competing against Costco because the
Exactly.
Kirkland brand may then
Yeah.
push you to innovate further. I think about the golf ball market, golf. They have a great
Yeah.
golf ball that they make, and it pushes the other manufacturers because it's a great
Exactly.
product.
And Costco will tell you, and I would highly recommend the Acquired podcast for Costco is also phenomenal.
Okay.
I know in health IT circles, everyone's excited about the Epic
Yes, the
episode.
5 hour epic.
Yeah. But for Costco, they talk through the rationale of when they vertically integrate with a
Hmm.
Costco with a Kirkland offering, and it really is when they feel like their offerings within a product category are not creating the value that they should be.
Okay.
But the other thing that Costco does is their margin is 14% max
Mhm.
for non-Kirkland brand and 15% max for Kirkland brand. So they also try to stay neutral even from a financial perspective
Sure.
to just always be trying to bring the best products to market.
The Costco analogy makes it does take what you've talked about of making AI seem less scary, right? Because Costco is something that is embraced, people trust, as you talked
Yes.
about.
And so you do have to have this distributor that you trust.
Yeah.
And you need to have a distributor that is savvy on how to evaluate the products that it's looking at potentially bringing into the marketplace. And that's where we think we're not the only ones, but I would say that we're part of the small community of folks who've been doing this research and doing implementations for a decade plus across a number of different use cases where we're very well positioned to try to curate that marketplace.
You've already touched earlier on the sort of extremes on that space, right? In terms of some people have extreme excitement about AI, some people have extreme anxiety. From you and I talking about it, and from hearing about what you're working on at Vega, I know a little bit about where you fall, but where are you on the spectrum as it relates to AI and healthcare, and what do you think that next big change is going to be?
Yeah, no, I mean, it reminds me of a longtime kind of mentor role model being at Duke is Rob Califf.
Mm.
And I honestly forget if where he attributes this quote to, but it's a quote that he would often repeat, trust in God, all others must bring data. So, I mean, we live in the Bible Belt,
Yeah.
and the idea being, show me what works.
Okay.
And there is AI that works, and there is AI that has positive impact on clinical outcomes, on administrative burden, on financial efficiency, on patient experience. It's not all AI,
Sure.
and you have to have the resources, capabilities to parse what works and what doesn't. And that's obviously what we're going to be trying to do through Vega Health. But I think more broadly, it is this balanced view of it's a very exciting time. The technology is real, it's having impact. There's also a lot of commercial interests at stake that are trying to maximize the enthusiasm from the investment markets. So you have to just show the data. And I think that's true for everyone trying to commercialize AI right now.
Mark, this has been a great conversation. It's always risky when I'm listening too much to the person I'm interviewing because I have to drive what we're going to end up talking about. But this has been such a fascinating conversation. Thank you so much for bringing it to some of our members as part of our High Five podcast. And please make sure that you're subscribing to us for those that are listening on YouTube and Spotify and Apple. And Mark, I know AHIMA members will see you in the future. I look forward to talking to you again soon.
Thank you. Have a good rest of your day.